Good morning, everyone. I'm Debbie Hart, and I have the pleasure of serving as the president and CEO of BioNJ. I hope that you, your colleagues, your families are staying safe and well in this just ridiculous time that we're in. I'd like to thank you for joining us for today's important and very timely conversation. A special thank you to our HR committee for putting today's program together, and Martin Rexroad in particular, whose idea it was. And we realize how busy each and every one of you are, every day, and in particular at this critical time, and also the challenges that this particular topic is posing to so many of you. So again, we're very grateful to have you with us, and we do hope that you'll learn some things today. So now that we are literally exactly 1 year in and vaccines are a reality, thankfully, there's just so much to think about and plan for. And we're delighted to have a very knowledgeable group of experts who are with us today, and they will give us an update on the virus, the variants, and the vaccine. Actually, you'll hear from Dr. Strom of Rutgers in just a moment. They'll share valuable insight and guidance to help us develop a plan for returning to the office as we move into this next phase of the new norm. As the Life Sciences Association for New Jersey, our mission at BioNJ is to make sure that New Jersey is a robust life sciences ecosystem where innovation is unencumbered and patients can then access that innovation. Today's event is an example of the programs and resources that we offer our members in an effort to support your work and the future of medical innovation. Before we kick off the program, a special shout out to today's sponsors. So PTC Therapeutics and Faegre Drinker. We could not do this without both of you, and we very much appreciate your support. We're pleased to have Lynn Anderson from Faegre Drinker and Martin Rexroad from PTC as part of today's program. Lynn and Martin are co-chairs of our HR committee, so we are keeping them busy. Thank you, Lynn and Martin, for all that you do throughout the year for BioNJ and leading our HR initiatives and programs. So let's get started. This is a listen-only webinar, so we encourage you to submit questions via the Q&A box. We have a good-sized group on the line. We're expecting to gain more as we go. And we promise to try to get to as many of your questions as possible at the end of the presentation. If we don't get to it, we will follow up with you after the webinar. Also, I should tell you that our speakers have generously agreed to allow us to share their slides, which we will do tomorrow. So watch for that. So it's truly an honor to introduce our first speaker. He is just amazing and wonderful, and has spoken for us so many times, and in fact, two times just this week. So, and he's very busy in his day job, as you'll pick up if you haven't heard him speak before. So I can't think really of a more knowledgeable leader to help us understand the virus, the variants, and the vaccine. In addition to being an epidemiologist and internal medicine physician, he's the chancellor of Rutgers Biomedical and Health Sciences, as well as the executive vice president for health affairs at Rutgers, the State University of New Jersey. So I would like to now hand it over to Dr. Brian Strom. Dr. Strom, thanks so much for being with us, and the floor is yours.
Thank you, Debbie. It's my pleasure. Can I have my first slide, please? And the next slide, please. So what I'm going to briefly go over is really the state of the pandemic right now, with a little bit of a plug for Rutgers, the contributions in the last year. I'm going to begin with what is SARS-CoV-2, the virus, and what is COVID-19. SARS-CoV-2 is a strain of severe acute respiratory syndrome related coronavirus. There's lots of coronaviruses. We get infected with them every year as colds. SARS is the more severe acute respiratory syndrome virus, and SARS-CoV-2 is the one that we're struggling with right now. It was named SARS-CoV-2 in February 2020. The disease it causes was then named by the WHO as COVID-19. So the virus is SARS-CoV-2, the disease is COVID-19. It was identified in late 2019. It was epidemic by February 2020 and declared a pandemic by WHO on March 11th, 2020. All ages are susceptible to infection, mostly via aerosolized particles. In the beginning, there was a lot of concern about surfaces. We now know that transmission by fomites, by surfaces, seems to be much less common, but rather aerosolized particles, both small and large, are the primary way it's spread. Median age of infection is about 50. There's 405 therapeutic drugs in development. Some have shown some benefit. So far, disappointingly few, but some. Outside of public health interventions, and we'll talk a little bit about that, vaccination is anticipated to be the most effective strategy for prevention and control. And as Debbie alluded to, fortunately, we now have that as an option. Next slide, please. Recently, in the last few weeks, JAMA reported COVID-19 as a leading cause of death. This December 17th JAMA article noted that by October 2020, COVID had become the third leading cause of death for people aged 45 and 84, exceeding chronic respiratory disease, motor vehicle accidents, drug overdoses, suicide, and homicide. And it became the second leading cause of death for people over age 85, less than heart disease, but greater than cancer. So this is having a massive public health impact. Next slide, please. The risk by country is shown here. And until a week ago, the US was red. We are now orange, so it's much better. There are not that many, given where we are in the pandemic now, there's not that many red countries left, which is very much a good thing. Next slide. Until a week or two ago, the whole country was red. Now it's just the Southeast and the Northeast. And none of them are the dark red, the severe outbreak now. Here in New Jersey, we're still in the active or imminent outbreak stage. Next slide. And if you look at New Jersey specifically, until a week ago, every county was red. Now we've got some orange counties, which is nice to see. New Jersey, the US ranks 37th highest risk of COVID in the world. New Jersey ranks 4th of the 50 states in the US. And we have daily cases now 33 cases daily per 100,000 as 7-day moving averages. Next slide, please. As of February 23rd, so these data, which of course change hourly, but this is 2 days old, cumulative number of confirmed cases worldwide is about 112 million. And again, that's confirmed cases. There's probably undoubtedly 2 to 3 times as many total cases. Cumulative confirmed cases in the US, 28 million, again, confirmed. Real cases is probably 2 to 3 times more than that. Deaths in the US have now exceeded 500,000 and continue to go up. Deaths in New Jersey have are approaching 700,000 deaths. So we're seeing as many deaths nationwide and in New Jersey as in almost all of the wars in our histories put together, to put it in perspective. Cumulative number that's cases in New Jersey. Cumulative number of deaths in New Jersey is approaching 21,000. Current hospitalizations 2,000. That is a drop, and I'll show you some of those data shortly. Currently on ventilators, as of 2 days ago, 281. Intensive care units, 451. Unlike in the spring, we are not at risk of running out of ICU beds or running out of ventilators, fortunately. Statewide positivity rate as of last week was 7.38%. That is a big improvement. WHO worries when you get above 5%, that is of all tests done, what proportion are positive. If it's above 5%, the pandemic is still doing badly and expanding. We are above 5%, but we've been above 10% for a long, for many, many weeks now. So this is definitely an improvement and a drop. Rate of transmission now is 0.86. Rate of transmission means for every case that exists, how many cases does it create? A rate of transmission greater than 1 means the pandemic is spreading. A rate of transmission less than 1 means the pandemic is shrinking. So it is shrinking in New Jersey, but rate of transmission is less than 1, but it is shrinking from a very high level. Next slide, please. If you look across the US, we have now had 3 surges, one in the spring on the left, in the middle over the summer, and then the most recent one. This is total number of cases. That's a little bit misleading. If you look at it, it's not that much worse more recently because there's a lot more testing. So there a lot more of the cases are now being correctly detected. Next slide, please. If you look in New Jersey, there are 2 surges. We never had a surge in the summer. We had the one in the spring, which was horrendous. We had the one that we're now beginning to come out of. You can see it's improving. the rates, numbers of cases are going down. It looks like it was worse this winter than it was in the spring. Again, that's misleading because we know about a lot more of the cases because there's a lot more testing. By the way, that one peak is an artifact. You can see immediately after that, the next day has zero. So these are data from CDC. It's in their website. Next slide, please. If you look at hospitalizations in New Jersey, we peaked in hospitalizations last spring when we came very, very, very close to not enough hospital beds, not enough ventilators, not enough ICU beds, and needing to be in a situation like Italy was in and New York had been in, of people sharing ventilators and having to make choices to take people off ventilators and let them die. We didn't get there in New Jersey. I'm happy to say we were at that threshold, but we never exceeded that threshold, unlike Italy and New York. This winter, we've had another big surge with hospitalizations, and as you can see, it's on the way down now. So we are doing much better now than we did. Again, Thanksgiving, Christmas, New Year's, all hurt. And each time it led 2 weeks later to an increase, and an increase on a larger baseline. But now we're doing better. Next slide. COVID-19 deaths, these are cumulative numbers you can see here. The deaths continue to climb, though at a lower rate. Next slide, please. So let me shift gears and talk about the 4 T's of battling COVID: targeting, testing, treating, and tracing. And I'm going to focus specifically on the testing and tracing in the public health measures. One of the things we found out about this disease in the interim year is, unlike many other diseases, much of it is passed by people who are not symptomatic, which is really problematic because you can't do a screen of are you coughing, are you sick, do you have a fever, and if you don't, you're safe. A lot of the disease, most of the disease, is passed by people who don't have symptoms. And so testing was pivotal, is pivotal, continues to be pivotal. It will continue to be pivotal. But then once you need to target your tests, not just indiscriminate testing, targeting it to high-risk people, because testing is not armor. And testing, people misinterpret it. It doesn't protect the person who's tested. It protects the people around the person who's tested to reassure them that that person's not positive. But just because they're not positive today, they can be positive tomorrow. And so it can give false reassurance. So you want to target your testing, you do your test, and then once you get the positive people are treated, and then in addition, critically important is tracing. You need to identify the testing, the positives, and contact them right away in a very insistent way. Find out everybody they've been with for the last few days and contact them, and quarantine both the people who are positive and the people they were in contact with. Rutgers has played a major role. We have trained all the tracers for the state. Before the pandemic, the estimated number of tracers that a state like nationwide would need is about 200,000. That a state like New Jersey would need about 2,000. The total number of tracers in the entire country was 2,000. Because of the dismantlement of the public health infrastructure that had been done. We have now trained well over 2,000 people for the state in our School of Public Health, and we've kept some of them for Rutgers' own tracing, testing and tracing as well. Next slide, please. And you see here the impact of that. If you look at the right-hand axis, you'll see this is Rutgers data, we never came anywhere close to the 10% the state was. We have always been much better than the state has been all along in terms of our positivity. And if you look, and again, the bars are percent positivity, the bars are the number of positives, the green line is the percent positivity. And you can track what has happened. So if you look last summer when our football team returned, the football team returned, and despite a lot of efforts to try to keep everybody isolated, there were some people who didn't follow it, resulted in a pandemic. With the aggressive testing and tracing, we were able to push that down. The students then returned in the fall after Labor Day. Again, there was another peak, And with aggressive testing and tracing, we pushed it down. Halloween occurred, parties following, again, there was a peak, pushed it down. Thanksgiving, again, there was a peak, pushed it down. Christmas holidays, and now students have returned for the next semester. And again, you see, each time you see a peak occurring, each time we've been able to successfully control it. We've been able to successfully control it with the aid of aggressive testing and aggressive tracing once the tests are in place. The slope tends to be going up, which is concerning. As you can see, of the green line in general on average, but fortunately in New Jersey and in the world, we've now turned to a beginning to go down. Next slide, please. And we've done this with a lot of publicity, the student health campaign. We have stickers like this on the in buildings. We have stickers like this on the ground, on the streets. We have stickers like this all over Rutgers. We have a large social media campaign in order to try to educate the students, because unfortunately, the students too often still think that they are immune. And too often think they are invincible in the process. And even this fall, this spring, when we had a group of freshmen come back who had not been in the dorms in the fall, we had another peak, as I showed you. And as we quarantined some of them, some of the answers we got was, oh, okay, I understand I need to be quarantined. Let me just go to this party first. Clearly not good public health behavior. So a large education campaign has been needed in order to keep Rutgers as healthy as it has been. In most states, the state universities have been a source of disease, infecting the rest of the community. We have been a source of health relative to the rest of the community. Next slide, please. We also have been pushing the state's free exposure notification app, which again, I encourage everybody on the phone, on the call to download as well. Doesn't matter whether you use an iPhone or Android. What it does is it tracks people who are in Bluetooth range of view. Nothing is reported to the state, but nothing is saved. But if one of those people turn positive in the next 24, 48 hours, you will be notified so that you know that you were in contact with somebody who turned positive. So it's an electronic version of doing tracing. Next slide. Moving on now to vaccines. Typical vaccine development on the left-hand side is preclinical testing, phase 1 safety trials, phase 2 trials, expanded phase 3 efficacy trials, proving it's effective, early or limited approval, and then ultimately final approval. Typically on average 73 months to completion. The remarkable thing that happened here with the responsive, amazingly responsive pharmaceutical and biotech industries funding helped by Operation Warp Speed is we now have vaccine approved in 14 months. And we have 2 on the market, as people know, and probably tomorrow the J&J vaccine will be approved by FDA and next week by CDC, and then by later next week, hopefully we'll have the third one on the market. 2 more probably will be on the market by the summer. Next slide, please. Leading vaccines, Pfizer and Moderna are both very novel techniques using messenger RNA technology, approaches that have never been used in people before. Side effects as listed there. Severe side effects, allergic reactions have been extremely rare. There was just a paper in Lancet, I think it was, or JAMA, a couple of weeks ago quantifying it. And severe allergic reactions, anaphylactic reactions are less than 1/10, close to 1/20th of the rate of penicillin. So these are extremely safe vaccines. They're also extremely effective vaccines. Remarkable efficacy. They would have been approved if they were greater than 50% efficacy. That was the FDA standard, and we're looking at 95% efficacy. The J&J vaccine is an adenovirus vaccine. 1 dose, though they're doing studies now of a 2nd dose, and with 1 dose, they already have 66% efficacy. And as I said, the EUA is likely to be approved by FDA tomorrow. The AstraZeneca vaccine is a 2-dose adenovirus vaccine. Next slide, please. Sorry for the text. These are my kids. I can't turn it off and still be heard. How do we return to normal? Well, we're never going to really return to normal. We will learn to coexist with this virus. But the key to this is herd immunity. On the left-hand side, you see each of the general population are the blue figures. You have one sick person in the middle, and that sick person, in interacting with the susceptible people around them, contaminate those other people. And this is a virus which uncontrolled has a rate of transmission of 5. So one person will contaminate, if dealing with just pure susceptibles and no public health measures, 5 other people. And that's what you see on the left side, and that's how this pandemic started, and that's what we were dealing with a year ago. If you get to herd immunity on the right-hand side, that one sick person interacts mostly with people who are immune. And so the disease doesn't spread because those people are immune, and there's only one, in this example, a susceptible person they came in contact with and spread the disease to. That's the goal, is herd immunity. That would they solve the pandemic. You can get herd immunity in 2 ways. One is by everybody in the population getting sick, and the death rate and sickness rate there would be far, far from tolerable. The other is vaccinations. Next slide, please. What are the opportunities and obstacles here? Vaccination provides a pathway to herd immunity. We've seen it with measles, where we've seen it with other diseases as well. We actually wiped out smallpox, the only disease to be wiped out off the face of the earth with vaccination. The percentage of the population needed to achieve herd immunity is not clear. We won't know that until we get there. Is it 70%? Is it 80%? Is it 90%? What is it that's needed? The trouble is we're not going to get that high. There's substantial vaccine hesitancy and competing with vaccine acceptance. There's lack of trust in the medical establishment, made worse in the last 4 years, medical establishment and government agency, safety concerns, the history of systemic racism faced by minority populations who are underrepresented in the studies, and mistrust research. And for all of these reasons and others, there are a substantial number of anti-vaxxers, about 25% of the population, who never take any vaccine. We will probably not achieve herd immunity with 75% uptake. Ideally, we would. It remains to be seen, particularly given how effective these vaccines are. But there's a substantial chance that we will not get there. And in addition, for now, we're not vaccinating kids. So they represent because the vaccines haven't been tested in kids yet. So they represent a group of people who can continue to get the disease and pass the disease to others, even if even if they don't get sick themselves. The other issue is the lack of infrastructure, because we've taken down our public health infrastructure in the country, and the politics of the last 4 years led to varied, lengthy implementation periods and inconsistent policies across federal, state, and local governments. Next slide. Other issues, mutations and variants. People have been reading about them in the press. Novel genetic variants are emerging, not a surprise. Over time, viruses, the history of viruses is they mutate to get more contagious and less virulent. And so we're now seeing virulence emerge. Virulence are a public health concern due to increased transmissibility and virulence, at least right now, the ones that we know about. The spread of variants exceed vaccine production and distribution. Certain vaccines or antibodies may, in theory, be less effective or ineffective against the variants. And the big issue is inadequate surveillance. We know about the UK variant. We know about the South African variant. We know about the Brazilian variant. We don't know, until very recently, we don't know about US variants because we haven't been testing. We haven't been looking for them. Yet we have most of the disease in the world. And so we're going to have most of the variants. There have been at least 7 variants circulating now in the US. A New York variant was just reported this morning. We hope, we've given up waiting for the public health authorities, and we hope to use our Rutgers specimens and our Rutgers labs and be looking for variants, and hopefully we'll have results by tomorrow in terms of variants in our populations, because we do think at least the pandemic, the mini epidemic we're having in our dorms are clinically behaving like variants. We need to know about them to prepare for them from a public health point of view. But these changes we're seeing in the spike protein cause concern, and ultimately could well lead to the need for booster vaccinations with variations on the existing vaccines. Fortunately, the vaccines can be produced so quickly that that is a feasible option. Next slide, please. Other obstacles: over-optimistic expectations of vaccine efficacy, premature abandonment of public health interventions that I talked about. Critically important, if we abandon public health interventions now, the vaccination campaign is fantastic. It's accelerating, which is fantastic. The availability of vaccines is increasing, which is fantastic. But we can't stop doing public health interventions. If we stop now, especially in the presence of new variants, we're going to see probably a fourth peak, a fourth surge in mid to late March due to the variants. And if we abandon the public health interventions now, it's going to be much worse and much sooner. It's critically important they be maintained. We don't know yet about efficacy in children of the vaccines. We don't know about safety in pregnant women or other populations. There's issues with the vaccine in terms of government mandates. Can it be mandated? Questions of encroachment of civil liberties. Can employers mandate it? Can we get to a high enough vaccination rate in order to achieve it? Herd immunity. Next slide, please. This is the state of vaccinations in the US as of 2 days ago. 82 million doses distributed, 65 million administered. New Jersey, 1.7 administered, with about 1 million, over 1 million people now getting first dose, and over 500,000 getting second doses. Next slide. The rollout in New Jersey is roughly analogous to the recommendation of CDC. So first were phase 1 healthcare workers and residents and employees in long-term care facilities. Next was phase 1B, which is what's now underway and has changed some over time. And I'll talk about that. And phase 1C remains to be seen. And eventually we'll have enough vaccine for the general population, probably, hopefully by July. Next slide, please. On Tuesday, December 15th, the first New Jersey COVID-19 vaccinations were delivered at New Jersey Medical School at the University Hospital Vaccine Clinic. That's the dean of the medical school on the left getting it as one of the first in the state to get it. On the right is me. I was not one of the first because I'm low on the 1A list, but I did get it, and I want to make that point. I've spent my career studying drug safety and vaccine safety, and felt and feel these vaccines are safe enough. That certainly I've taken it, and all my family have taken it as well when they qualify, in terms of the different phases. Next slide, please. As of January 14th, the qualifications were expanded to include first responders, police and firefighters, persons age 65 and over, persons age 16 to 64 with at least one chronic condition that are listed here. New Jersey Department of Health also expanded healthcare providers who are authorized to administer vaccines. Because one of the issues is we took down our public health infrastructure, so we would have to rely on our healthcare infrastructure to give the vaccine. And the healthcare infrastructure was already enormously stressed treating people with the disease. So with that change, the Department of Health, for example, allowed us to mobilize our large number of students, pharmacy students, medical students, nursing students, to be able to give vaccines under supervision, to be able to assist in this. We now have in the state plenty of adequate vaccinators. What we're short on is vaccine. Next slide. Multiple options for where to get vaccinated. I urge you all to register with the state at this website. There's a website to register, and there's a website giving you locations where you can get the vaccines. Next slide. New Jersey now has 295 vaccination sites. This is as of a week ago. That was before the pharmacies were allowed to give them as well. These are closed points of dispensing that are transitioning to open points of dispensing to serve broader communities. There are also 6 mega sites that are capable of handling large numbers of people very quickly. Next slide. The limiting issues are vaccine supply, confusion, particularly at the federal level. The states, and New Jersey is no exception, reporting that vaccine supply is running low, and there's a misalignment with reported vaccine delivery numbers. The state reports that New Jersey has the capacity to administer, this was 2 weeks ago, 470,000 doses per day, but was receiving only 100,000 doses per week. There were 4 million people in New Jersey authorized now in phase 1A or 1B to get it. At 100,000 doses a week, 4 million and 2 doses needed for each person, it's going to take a whole lot of weeks to get to 4 million people covered. Fortunately, the number of doses is available is increasing, but we're still very far behind. The number of places to get the vaccine is also increasing. But again, that increase has not been as as the feds developed a program to give the vaccine via Rite Aid and CVS. That's not been the rate limiting step, though. The rate limiting step is getting enough vaccine. The J&J vaccine coming online will help some, hopefully late next week. And as they gear up to produce more vaccine, and similarly, Moderna and Pfizer are gearing up to produce more vaccine. Next slide, please. This is a series of FAQs. I don't expect you to be able to read that. The point is to show you the website. Lots of information on the Rutgers coronavirus website if you would like to be able to learn more and read more. Next slide, please. Almost finished. Public health interventions, however, remain the most effective way to prevent COVID-19 infection. As more of the public becomes vaccinated, premature abandonment of masking, physical distancing, and hand washing will only prolong the pandemic. It's critically important that people continue the public health interventions. We don't yet know how effective the vaccines are in preventing transmission. The data beginning to come in are encouraging. We know the vaccine prevents the person who got the vaccine from getting sick. We don't know yet whether it spreads, whether it prevents the spread to other people, though again, the data are encouraging. The other thing is realize even if 100% of the public received vaccination, and it's not going to happen, the first dose provides maybe 50% immunity, second dose 95%, it still leaves 5% of the population vulnerable, and 5% of a large number of people remain a large number of people. So still wear face covering, still watch your distance, still wash your hands. Next slide, please. I'd also like to point out to people certain key Rutgers accomplishments. Rutgers developed the high throughput viral testing that may be the largest in the US for a single testing site, 20,000 a day with 24-hour results. Development and evaluation of as well of the so-called saliva, the Rutgers saliva test, first in the US to obtain FDA approval in the US, and development and testing of the Cepheid first point of care tests with the results available in 45 minutes. Next slide. We developed a Center for COVID-19 Response, which we mobilized within a few weeks of the initiation of the pandemic. This new center, headed by David Alon at New Jersey Medical School, has already gathered over $30 million in extramural support, has 30 plus clinical trials involving over 100 researchers in multiple disciplines. Rutgers is the only COVID-19 site in New York as part of in New Jersey as part of NIH's Operation Warp Speed. We are involved in clinical studies with 17 different public and private sponsors of vaccines, therapeutics, and diagnostic trials as well. Next slide, please. We hosted the Moderna vaccine trial in Newark, conducted in collaboration with University Hospital as one of 2 sites for phase 3 trials in New Jersey. We're preparing that to be available for the Sanofi trials as well. We were for the J&J trial, we were the second largest study site in the world in terms of number of people we enrolled. Second, the third highest was Columbia. That is not Columbia University, but the country of Columbia. We enrolled more people than the entire country of Columbia, which was the third most highly enrolling site. Next slide. Finally, or almost finally, I'd like to thank our healthcare workers from the bottom of our hearts. This is a sign from the New Jersey Turnpike. Again, we have 1,000 physicians who, in partnership with our RWJ Barnabas colleagues, last spring were literally killing themselves. We had to provide housing. It wasn't safe for them to go home because of the risk of their catching the disease and spreading it, particularly given the lack of personal protective devices. They're catching the disease and spreading it to their families. They have been incredibly hardworking, incredibly effective and successful in saving the lives of all of the rest of us. Had a pause over the summer, and this winter are going through it again. The PTSD there is remarkable. Next slide. Lastly, I'd like to remind everybody, we isolate now, we continue to isolate now. So when we gather again, nobody is missing. We have lost 500,000 Americans to this. We need to be patient, and we will learn to coexist with this virus. And the vaccine developments by this industry have just been phenomenal and will be an enormous savior for the world. Next slide, please. Next slide. I think this is the last slide. Yep. So you can drop the slides.
Great. Thank you so much, Dr. Strom. That was just, riveting, a little alarming. So maybe start off with a question. When do we get back to normal? Please say we do. And then what does normal look like?
Yeah. So when will we get back to the normal of a year and a half ago? Never. This is a virus which we will learn to coexist with. When will we get closer to normal? Probably this summer and maybe fall. We'll continue to wear masks. We'll continue to distance. But we at Rutgers are planning for an in-person fall. And we think an in-person fall is realistic because enough people will be vaccinated, and it will probably have to be a hybrid with a combination of people being vaccinated, and if people are not vaccinated, they get tested, and hopefully the testing, which is markedly improving, if we have accurate enough and rapid enough and cheap enough tests, those people who aren't vaccinated just get tested. So people will come in with a viral passport or a negative test result. And with that, be able to go back to dorms, to stadiums, to restaurants, to theaters. But again, it's coexisting. We'll be live for classes in the fall, but we'll be live with still masked and distanced classes. The large lectures will still be done remotely. We'll do the medium lectures in large lecture rooms. We'll do the small classes in medium rooms to allow spacing with masks accordingly, and deep cleaning of facilities and so on accordingly. So we will be much closer to normal by later this year. We'll still be wearing masks. Maybe by 2022, we will be able to start dropping the masks. Certainly even now, CDC will be coming out with guidance in the next few days about people who are vaccinated. So for example, I've begun to go to my office and told my staff I will have meetings again in person, but only one-on-one and only people who are vaccinated. Everything else remains remote. So I think that's what you're going to see as a process where people are vaccinated, their lives will begin to return more toward normal over time. And it's not going to be a switched. But we're also never going to get completely back to normal. We've learned a lot, including being able to do conferences like this remotely. I suspect a lot of the new behavior is going to continue indefinitely.
Mm-hmm. Interesting. So do you see, at some point, is there another COVID-19?
Oh yeah, this has this kind of, we had a bird flu a few years ago. Fortunately, it didn't spread easily. It was more virulent than COVID-19. I think this is our new future. This is not a surprise. It has been foreseen for decades. There will, between climate change and population expansion, so the general population is living more adjacent to animals. With that, we will continue to see diseases jump from animals to people. It's always been the case. It's just going to happen more because of proximity. The other piece of it is air travel. So people spread disease much more easily. So that is absolutely going to be the new normal. WHO certainly has been on top of it, will be on top of it. Hopefully we'll have the resources to be on top of it. CDC traditionally has been, and including internationally has been. There have been people from CDC in Africa, in China, in places all over the world to find those diseases and jump on them in advance. That got dismantled over the last 4 years. That will get restarted again now. Going forward. But I think we have to anticipate that there will be, no question, there will be other zoonotic diseases that came from people into animals. And whether or not they're, this one was worse than others because it was so transmissible. It was more transmissible from person to person, even from the flu. In the past, most of them, like the bird flu, are of course birds. A few of them went to people who were living with the birds. They didn't go person to person. This went person to person, and it goes person to person easily, which is problematic. SARS, the prior SARS, was more virulent, much more virulent, killed a much larger proportion of the people who got sick. Fortunately, it didn't spread as easily. And it's that combination of virulence and contagion which are the problem. And again, this one will eventually peter out as it gets more contagious but less virulent and becomes closer to a normal cold. But there'll be others.
And we'll be better prepared for them. Is that a true statement?
I think it's absolutely true. We'll be better prepared for it in lots of ways. We could have been much better prepared for this. We were 10 years ago. We were more prepared 10 years ago than we were when this happened. Once we saw what happened in Wuhan, we still had a few months we could have prepared. We could have geared up right away with more PPE. We could have geared up with more equipment. We could have prepared, begun the research to be able to develop vaccines and so on, even earlier. We waited too long, but this time certainly we will be. If we don't dismantle it again, we'll be more prepared. And with that, there's going to be more resources that go into biomedicine and into the biotech industry in order to prepare for it accordingly. The biotech industry obviously is absolutely central, pivotal to all of this. It just, hopefully the country doesn't forget. The problem is the prevention is not as sexy as treatment because you never see the cases that got prevented. And so when money gets tight, preventive measures like public health are one of the first things that get cut. Hopefully we've learned a lesson.
I certainly hope so. Would you mind talking, please, about J&J and the J&J vaccine versus the Pfizer and the Moderna, the differences in safety in efficacy, and what that, it sounds like even though it sounds like a big difference, it's not that dramatic.
It's not that dramatic. So the J&J vaccine is a great vaccine. It has the advantages, as I mentioned, of one dose, and you don't need the freezing. So it's available. You can use it in rural areas. You can use it in third world areas. You can use it in people who can only be at home, who can't come in for the vaccines. A number of advantages. The efficacy difference is probably misleading, the apparent efficacy difference, for a few reasons. One is that it's one dose only. J&J has a trial underway of 2 doses. With a second dose, you'd expect it would be more effective. Flip side is what they're beginning to look at the mRNA vaccines, the Pfizer and Moderna vaccines, as how much efficacy do you get with one dose? Because much of the efficacy is with one dose. So that that difference is misleadingly different in terms of one dose versus 2 doses. The other difference is you're looking at a different time. The mRNA vaccines were tested in populations that without the variants. The J&J vaccine was tested in population with the variants, including particularly South Africa, where the variant looks like it's resistant to vaccines. And in fact, the AZ vaccine, the AstraZeneca vaccine, has stopped being used in South Africa because of lack of efficacy. So it's a little bit of apples and oranges when you compare the data. I think from a scientific point of view, the important thing to realize is the criteria for approval is greater than 50% efficacy. J&J clearly is greater than 50% efficacy. And it's much greater efficacy even against serious disease. And again, its outcome was disease in general, and serious disease, it's very effective at. So this is a really good vaccine that we'll have 20 million doses, 2 million doses next week, 20 million doses by March, and 100 million doses by June, and clearly will help this effort going forward.
Terrific, from a terrific New Jersey company. I'm so proud of that, and so proud of all that has happened at Rutgers, well, overall, but also, your direct involvement in clinical trials and the development of the saliva test. And so we're just so proud of Rutgers, Dr. Strom. We're so thankful for your participation today and what you're doing day in, day out to make a difference. So thank you, and Godspeed to you.
My pleasure. Good luck, and thank you for the work you do and your industry does. It's
Thank you.
pivotal.
Take care.
Take care. Bye-bye.
So riveting, to say the least. So, okay, let's see. So now we have the lay of the land. And now we will hear a little bit about, how we react to that and what we do about it. So it's my pleasure to introduce our next presenter to discuss preparing our new work paradigm, people, and policies. I would like to welcome and again thank for her great participation in many things that we do at BioNJ, and her great leadership on this important topic that we'll hear from her on now. So one of our most popular speakers on so many topics, though, a partner at Faegre Drinker, Lynn Anderson. Lynn, the floor is yours.
Thank you very much, Debbie. I appreciate it. And thanks for having me. And Dr. Strom, that was amazing. That really gives us the foundation for what we need to talk about next, which is what we do in our workplaces. So if we go to the next slide, what we know and what we consider. This is something that we've been talking about in terms of COVID-19 for a year. I remember Debbie called me, I think late March, and always looking out for her BioNJ members, said we need to put something together quickly because we have to figure out what to do on the ground with COVID-19. And I think, Debbie, we put something together in 2 or 3 days for the members. And here we are a year later, or almost a year later. But every day I'm talking to clients about now, not just COVID-19, but what we do about the vaccine. And at Faegre Drinker, we have an interdisciplinary COVID-19 task force that we are now doing a special vaccine focus on this because there's lots of different aspects. So when we think about the vaccine, if we go to the next slide, there's some time, and we'll skip over because I really never like looking at myself, to the next slide. It's a debate about what we're going to do. And the next slide is, here's the compendium. Are we going to stay neutral? Are we going to say, look, if folks want to get it, they get it, whether it impacts, whether you come back to the work site or not? That neutral, the advantages of being neutral is it limits liability down the road in terms of I was excluded from the workplace because I didn't get the vaccine for whatever reason that is. Or I got the vaccine because I felt I had to, or it was a work mandate, and now I feel that these are the side effects that I'm dealing with. Do you strongly encourage? That's one step short of a mandate, but try to get as many folks to engage as possible. We're in the health industry. We want to try to work as a public service to get everyone towards herd immunity as much as possible. Or do you actually mandate it, which if you want to come back on site, you need to have the vaccine. These are things, now's the time to discuss this. Now's the time to figure out where you may want to be on that compendium. But it's with anything, and if we go to the next slide related to COVID, it's complicated. There are a lot of things that will go into that decision-making process. We'll talk about them. There's a lot of legal issues. There's a lot of fluidity in this. We've heard the science. Dr. Strom gave us a good foundation for us to now have this discussion. When we talk about the EOC and the CDC, we've heard about the fact that we still need to have these public health initiatives weaved into this. It's not going to be a silver bullet to have the vaccine. There's an interplay here between federal and state law. The New York Times reported that as of Monday, only 5.9% of the workforce is fully vaccinated. So we do have accessibility issues. It's hard to mandate something that is not going to be available to our workforces. Possibly, I think July would be great. Practically, it may be much later than that. So lots of things that we need to think about. If we go to the next slide. So look, we all have probably seen a lot of things pop up in our email boxes, read on our news feeds, that the EOC said you can mandate the vaccine in December. But let's sort of break that down. Now, the EOC has historically said, look, as employers, you are not in the business of being healthcare treaters or healthcare providers, and you shouldn't be making decisions relating to employment, whether to, hire, fire, suspend employees based on their medical conditions, because you're employers, you're not medical providers. And this stems from a long history of, for example, people removing women from certain aspects, the factory floor, other jobs, not letting them travel when they were pregnant out of concern it would hurt the fetus or hurt them during their pregnancy, when there was no medical foundation for that. It was just a concern, a patriarchal concern, a concern. Also, for example, removing employees with diabetes from certain job positions because there is a concern they may go into shock or have some kind of reaction. Same thing with people with epilepsy. So the EOC basically said, you cannot make employment decisions on the basis of a medical condition or someone's physical condition, anything medically related, unless you have a direct threat situation where the employee is going to cause a significant risk of substantial harm if they are kept in the workplace. So what the EOC has done, and we are in a unique situation with this pandemic, has said the risk of spreading COVID-19 is something that we consider to be a direct threat. So that opens the door for employers to be able to do things like testing, take your temperature, things like that, ask questions in terms of whether you have a fever, whether you have, chills, shakes, all those questions, chills, aches, things that we see on the questionnaire. It's now opened the door for also mandating vaccines. However, built into that is the need to provide accommodations. And that would be if you have a disability that would prevent you from taking the vaccine, if you have a religious objection to taking the vaccine. And we also have situations, because the science is unclear on what the impact may be for pregnant and lactating women. And also, I think what's going to be considered is certain medical conditions that may not necessarily rise to the level of disability, but may give people pause, or it may have their healthcare provider say, I'm not sure you should take the vaccine. And we layer into that what we've heard about the anti-vax movement, and that will make things a little complicated. So if we go to the next slide, I think it's helpful to understand what does it really mean to provide accommodations? Because the one thing that the EOC is still saying is you still need to do this on an individualized basis. So it needs to be you have to analyze if someone says, I'm raising my hand, I'm unable to receive the vaccine, or whatever the reason is. You have to look and say, okay, does the employee pose a direct threat to others in the workplace? And let's hold that thought of direct threat, because I want to drill down on that in a couple slides. Are there other accommodations that are available, right? This is the process that we always go through as HR professionals when someone asks for a reasonable accommodation. Now, we have the CDC has told us, our departments of health have told us, Dr. Strom has told us, there are things like masking and distancing, installing barriers that can be used to reduce or eliminate. I don't think we're ever going to, even the vaccines don't eliminate the risk, that can be considered. But let's say that you still determine and you feel that the science is going to support you in that, or you may even have a state that gives you an executive order that supports you in that you can still ban the person from the workplace. The EOC has said that does not mean that you, just because you can say they can't return on site, that you should terminate them or fire them. You still have to see whether there's other rights that apply. For example, do they have family medical leave available? Do they have other leave available? And then you have to look to other accommodations like modified work schedules, um, remote work, things like that. So keep in mind that when you're considering whether you're going to mandate, it's still going to be a process in terms of how you're going to handle folks who are going to come to you regarding accommodations. The other thing is a reminder, as you know, with any other accommodation, that you cannot disclose that someone's come in terms of what the basis of the accommodation is, and also any retaliation for someone. So obviously we're concerned about claims down the road that someone asked for an accommodation, that there was a reasonable accommodation was available, it was denied, and so the termination was in fact a retaliatory termination. Next slide, please. So pregnancy and breastfeeding, again, here, we don't have science yet in terms of what is the safety with regards to women who are breastfeeding their infants. So I would urge a lot of flexibility here to the extent that you do have pregnant and lactating women that are asking for accommodations with regards to not taking a vaccine if you decide that you're going to mandate it. Next slide. Religious accommodations. Now, I get a lot of questions about religious accommodations. And I will tell you that, I've thrown up the definition under the EOC. Most religious accommodations generally don't come in under the framework of an organized mainstream religion. That does not mean that you can't accommodate. The EOC has also been very clear that you must be very uh, limited in terms of how aggressively you push for a request for supporting evidence, that it's perfectly fine to say, I'd like a little bit more information to understand the practice or observance that forms the basis for your objection. And that's fine, but that should be something that should be done after some careful consideration. We have a federal court out there that has said that veganism is recognized as a religious basis for religious accommodation because certain vaccines, not here, but there are eggs used in formulation of the vaccine. So just something to be sensitive about. And I think we're going to see a lot of folks raising this in the context of sort of the anti-vax as a religion. So this will be an interesting area that we're going to be dealing with. Next slide. Now, let's talk about this direct threat concept. And again, if you are considering mandating the vaccine, and you're doing this under the basis that it's a direct threat to the workplace, and there's a factor test that has to be considered. But here's where we anticipate you may have some challenges. We are all working remotely, except for folks obviously in labs, in some of your manufacturing facilities and distribution facilities. If you have individuals who you are now going to reopen the workplace, but you're going to say you are not allowed back onto the work site to participate, and if you don't take the vaccine, and I don't really have another way of accommodating you, we anticipate one of the challenges is going to be that, am I really a direct threat if I don't take the vaccine? Because we've had people in the office, right? Many of us have people coming in and out of the offices, even though they're closed, and they've been wearing masks and they've been socially distancing. So what is the difference if I adopt those precautionary measures that are mandated by the CDC, mandated by the state health department? So how am I causing more of a direct threat than my colleague who was working in the office 3 months ago wearing the mask and wearing and then socially distancing and washing hands? And then also, as we said, some vaccines are more effective than others. We're going to see that some vaccines may not be as effective against some of the variants than others. We anticipate that these vaccines may have a limited shelf life, right? Right now, we're looking at 3 months possibly. So, at what point does someone who's vaccinated become as much of a direct threat as someone who's not vaccinated? So it's a little tricky, it's a little complicated. So I think we have to take all that into account as you evaluate whether or not you're going to mandate vaccines as a condition to come back to the workplace. The other thing is obviously, have you had outbreaks? If you've had people coming into the workplace wearing masks and socially distancing, then arguably that you've managed the risk. And we go back to, right, is there risk of imminent harm? Is there a likelihood of potential harm? If you haven't had that much outbreak, then maybe there isn't imminent potential harm. So something to consider as you're evaluating where you're going to go. Next slide. So one of the things that you may want to consider is, do I do this on a job by job basis as far as the mandate for the vaccine? Do I consider what is the risk level for certain positions? And maybe I assess the mandate based on the risk level. And obviously there are certain high risk positions and there are lower risk positions. And you can figure that out based on what people are doing, how close they have to be to somebody, whether they can work remotely, all these different things. And then travel also is something that we're working into this assessment. And if we go to the next slide. So with travel, this is something that is evolving and we're watching this closely. So, earlier this month, the WHO said that right now we don't think you should have a requirement of a vaccine for travel. Now, for international travel. Now that may change. We're seeing some airlines talking about having a requirement, but I don't think we're seeing it yet. We're yet to see hotels, car rental, things like that that you need for travel requiring it. Immigration, we have an immigration group at the firm, and they tell me that two things that are popping up worth considering is China in November basically said that you need to have antibody tests for purposes of travel to China. The problem is if you get a vaccine, that may be a positive antibody test, and therefore you may limit travel. Also in the US, the EOC has said you can't do antibody tests because they're not yet reliable. So that shouldn't be a basis for making employment decisions. So that's going to get a little complicated to the extent you have people that are traveling to China. And then the second part of this is for green card. Part of a green card is a medical exam, which I think now COVID vaccines are becoming part of that exam. So it's going to be interesting in terms of how that's going to impact eligibility to become a citizen. So that's something to be watched. But the other thing I thought was really hysterical is that we've all been watching what happened in the industry with regards to cruise ships. Cruise ships is the one industry that probably will require COVID vaccines for cruise ship travel, which is probably not a bad idea. But anyway, this is something that you should be watching because I know many of us do have business travel, international travel as a component of some of our employees' jobs. And that may factor into whether you mandate the vaccine and how are you going to handle this. So next slide. So just to wrap up accommodations, again, keep on top of what's coming out of the EOC and the CDC. Make sure you have your documentation. If people are going to be requesting accommodations, just like we would normally handle accommodations, there should be request paperwork. There should be demonstration that you've engaged in the interactive process, you've looked at this, and that if you've made a determination that there is no accommodation, that you have a basis for that. So if it is challenged later on, you'll be able to demonstrate why. So, and then again, these accommodation requests do have to be treated confidentially, as we know. So, okay, next slide. Now, when considering whether or not to mandate, keep up to date of what's going on in the states in which you have employees. In Wisconsin, we have announcement from the governor's administration that they are not going to mandate vaccines of students or workers and may in fact block any mandates. We have a number of proposals that have been submitted in legislatures to ban or limit mandates, including some of those impact at the worker level, not all of them. New York has one that says you are going to ban mandates of vaccines, and then they also have one that's going to make it mandatory. And I think Dr. Stamm might have even mentioned that if you get to a certain a level of infection. And if we want to look on the next slide, what's happening in New Jersey, for those of you that are interested. So this was introduced at the end of, or in December. And it's interesting. So it would ban basically the governor, as well as any states or cities having a mandate. And as you may recall, early on there was a skirmish in COVID because a couple cities started issuing their own sort of citywide orders about quarantines and things like that. And the governor stepped in and basically said, we're going to do this on a statewide basis, so back off, which the cities did. But this proposed legislation would not allow any mandates that would require would mandates for the vaccine, except in limited circumstances for people that were basically in nursing homes or other long-term care. It's curious, it doesn't specifically talk about employer mandates, which might be different than mandates by the government, but does say that because we just don't know enough as far as safety and long-term effects, that's why we shouldn't have any mandates. So that's not, it's still in committee. There hasn't been much activity since it was introduced, so we're watching it, but I'm not sure what's going to happen with that. Next slide. All right, so let's say you've adopted a mandate, whether it's a partial mandate or for certain jobs descriptions, or it's a company-wide mandate. What if you have an employee who refuses? And next slide. This is a real risk. You heard the data from Dr. Strom, and if we look at the next slide, this was a survey that was done by PwC in January. At the bottom trend, while people are willing to, and they're increasingly willing to do things like wear masks, and that number, by the way, 72% has improved from when PwC started doing this surveys. But in terms of the ability to, or the willingness to provide proof of vaccination, which means, i.e., I'm willing to get a vaccination, 54%, which means you've got over 40% of folks that are not willing to be vaccinated. That's significant, or not willing to tell you if they've been vaccinated. And so if we go to the next slide, I can tell you from working with healthcare providers, large and small in New Jersey as clients who've had the vaccine now and have been rolling it out for a while, since December, we're seeing tracking 20 to 30% of those employees are declining, which is, to me, crazy, because these are people, this includes nurses that are declining the vaccine, for all the reasons that Dr. Strom said. So the reality is there will be fairly substantial portions of your employee population that will, even without a religious or a medical reason, refuse, decline the vaccine. And so, what do you do then? Do you say you're fired? Assuming they don't have a basis for an accommodation. The other thing we're seeing is a tremendous proportion of employees, Black and Brown employees, are the ones that are declining. And Dr. Strom reviewed some of those reasons due to distrust. So we are all engaging in a lot of DE&I initiatives, especially after the events of the summer. And do we want to automatically derail those initiatives by losing a substantial portion of our diverse population if they say, I am not comfortable taking the vaccine, and if it's my job or the vaccine, I'll hand in my letter of resignation, or you can fire me and I'll figure out where I go from there. The other thing is, as we said, the science is unclear about the impact with regards to pregnant and lactating women. So you may have a lot of women, especially younger women, that decline the vaccine. And it may be not just women that are pregnant or lactating, but women that are of childbearing age and are concerned about the impact on their ability to conceive, or once they are pregnant, the impact on their fetus. So are you going to be excluding disproportionately larger portions of women employees at a time when we are really struggling with the impact of losing women in the workforce because of the challenges posed by the COVID pandemic with loss of childcare and things like that? So these are things to think about when you have these discussions. The other thing is, if you have unions, before you make these decisions, you're probably going to have to bargain in terms of A, whether to mandate, and B, what happens if someone refuses the vaccine. So things to think about. Next slide. The other thing to think about is many of you are well aware, the vaccines right now only have emergency use authorization. What does that mean? That means it is a voluntary acceptance to use the vaccine. So there is no vaccine right now that has full FDA authorization. So if you were to impose a mandate right now, and an employee were to say, I decline because it is only an EAU vaccine and I only have to take it on a voluntary basis, and the fact sheets are very clear because they have to be, and I've got a link to the fact sheets for all the vaccines that are currently available. There's a very good question about whether the refusal to take the vaccine and then a subsequent adverse employment action would lead to a claim of a violation of public policy. So something else to consider. Now, at some point, I'm sure we will have fully approved vaccines, and that may be closer to the point where there is full accessibility, because we've talked about it's hard to roll out a mandate when the vaccine is not accessible to a large portion of your employee population right now. So something else to consider. Next slide. Other things to be thinking about, obviously we have a lot of, we're tracking and we're actually working with clients in defending COVID-related litigation already. We have a lot of claims that relate to OSHA violations, OSHA inspections, failure to provide safe workplaces. People feel that there's unsafe conditions. This will go both ways. People may feel it's unsafe because a vaccine is not required. I think those cases are easy to defend if there's no mandate for a vaccine. People may feel it's unsafe if they're required to take a vaccine that it's, again, an EUA vaccine, or a vaccine where it's unclear if they have an underlying condition that's not a disability, but that may be a risk condition for them. The other thing is, we've talked about the adverse effects and whether that other complications could in fact lead to workers' comp claims, et cetera. So hopefully we have limited adverse reactions to the vaccine. Administration process, when you mandate it, and what you need to do for that is something that you're really going to have to think through logically and dashboard out, but it will take a lot of administrative time on that, and making sure that you're preserving confidentiality. The other thing is, if someone says, I am not going to get the vaccine, and the question of why not, you're immediately getting into potential medical issues. So again, you've got to be really sensitive on that, and you've got to train so that managers aren't doing that, but you're pushing that over to HR so that it's not a situation where managers are getting and eliciting information regarding underlying medical conditions. Next slide. Okay. This is obviously a culture discussion, right? In addition to, I've tried to give you underpinning for legal considerations, but it's a culture discussion. So I would just tell you again, the buzz around the EEOC guidance that came out in December is that it's fine, global mandate to require vaccines for folks before they come back to the workplace. I think we've shown some of the things in terms of how it's a little bit more nuanced than that. And I will also tell you the EEOC has been clear that their mandate is to encourage vaccines, not to require vaccines. But whatever you do, you're going to need to have a policy statement on it, a communication to your employees. And I encourage clear, thoughtful, empathetic communication on why for your policy, whether it's strongly encouraging or mandating, so that you can make sure that people understand why you're doing what you're doing. And then building into that education, training, and obviously, you're doing this for safety, you're doing it for well-being, so that people understand there's a good reason for what you're doing. The other thing is, it's going to change things. The science is going to change. It's going to be evolving. And so with our COVID, your current COVID task force, your current COVID protocols, you will probably need to be tweaking and updating this policy as we go along. Okay, next slide. Now, there's going to be some practical things that we're seeing, and I just want to run through some of those quickly to help you think through some of these issues. Next slide. So proof of vaccination. Can you ask for proof of vaccination? Yes, you can, but it should be a yes or no and not a why not. The other thing is your proof is going to be coming from a pharmacy, from their doctor. In your documentation that you send to employees or whatever verification form you have, please include reminders that you don't want any medical information or private information. You're just looking for a yes or no. We will get to a discussion about whether we're going to need to know which vaccine. But again, be careful you don't get more than you should here. And the other thing is, it's going to be tricky because if you have a mandate and someone is not vaccinated, they may not want to tell you why. There are people that are pregnant that may want to not disclose it yet. There are people that have certain non-apparent disabilities that may not want to share that information. So something else to think about in terms of what kind of policy you're going to adopt. So next slide. Okay, here's where a lot of the things that Dr. Strom pointed out, really start to come into play. So are we going to need to track what vaccine was received? Because, some vaccines are going to be better against certain variants than others. Well, what if the New York variant really, certain vaccines don't work against the New York variant, or you have employees in California and certain vaccines don't really work against the California variant. The other thing is, how long do the vaccines last in terms of protection? Are you going to need to track dates when people had the vaccine so that you can kind of know when, if you're going to say it's mandated, but the science is telling us the vaccine's efficacy is really going to only last, the protection is going to last for 3 months, because the CDC is already telling us they don't know how long it's going to last. And we see some other things the CDC puts out there that seems to indicate they're looking at a 3-month window for the protection. Then do we need to say after 3 months, you're no longer allowed in the office until you get a booster or another vaccine? So these things are going to be very interesting. Right now, you can't ask, you can't require antibody testing. The EOC has said no to that because it's not reliable. And so it can't be a basis for making any kind of employment decision. So, at some point, maybe we will be allowed to do antibody testing, and that will be required as a condition to stay in the office if people, in addition to the vaccine. So things that we're going to have to be watching and thinking about. Next slide. Okay, on-site vaccines. I've had a lot of discussions with folks. I want to make this easy for my employees. I want to bring it on site so that they can do it, it can be done, they don't have to hunt for it. I'll get more people vaccinated. I do it for the flu. I agree in concept, this is a fantastic idea. There are a lot of minefields with this. One is just the biggest one right now, again, is the issue of accessibility. And it's just not accessible. We also have had discussions with clients, especially clients that have locations in certain areas that are predominantly diverse Indigenous populations. Do we want the predominantly, white company to be seen as having an on-site vaccine opportunity, jumping the line when the rest of the community, which is really at high risk and has a higher incidence of disease, doesn't have that accessibility. Also, right now, right, it's very clear the states are saying if you're in 1A, you get it, but if you're in 1B, you're not getting it yet, or if you're in 1C, you're not getting it yet. You don't want to be put in the position of having to make those decisions. And there's actually a clinic that had started to vaccine jump the line because they got through all of their 1As and they started with their 1Bs, which were school teachers. And the state was like, no, we haven't approved anyone to do 1Bs. And they're like, well, we had, a lot of vaccine left. So we just moved ahead because we didn't want to waste the vaccine. And the state pulled their license to administer vaccines. So, it's complicated now. It's really probably not even practical. But if you do it, the EOC has already said, look, the pre-screening questions are medical questions because they're eliciting medical information. And that's a medical exam, and that's going to get you in trouble as an employer, whether you do it yourself or if you contract with someone to do it and come on site. So think about this when you do, we're seeing this practically in the healthcare providers that are doing it already. When you do a flu vaccine, it's pretty straightforward, date of birth, all that kind of stuff. Everyone's either in a room, sitting together, but they can hear each other, or they're separated by curtains. When you're doing the flu vaccine, the COVID vaccine, it's the same kind of situation where there's a lot of opportunity for coworkers to overhear the conversations in the cubicle or the examining room next to them. And the questions are about your medical conditions, your medical history. People are asking questions. I have this, I have that. Is that going to be a problem for me? Am I going to have a reaction? And so there's a lot of medical information that supervisors may inadvertently hear about other employees. So if we go to the next slide, the only time the ADA is not going to be applying to those situations is if the vaccine is completely voluntary. But then understand if you're providing the vaccine, you can't retaliate against anyone who says, I don't want to do it. And we all know in these retaliation cases, if someone says, I don't want the vaccine, and then they get a PIP the next week, they're going to say it's because I didn't get the vaccine. And secondly, it doesn't solve that inadvertent disclosure problem we talked about. So for purposes of the safest way to do it is to just do everything you can to provide information so folks can get it from a third party that you're not contracting with. And I know that doesn't necessarily make everybody happy, but if you're just looking for advice on limiting your risk and a lot of the complications that arise with doing a clinic at this point, that's probably the easiest answer. Next slide. Okay, other practical considerations, obviously, there's complications, making sure you're providing appropriate leave. We have paid sick leave in New Jersey for vaccines. The sick leave law does cover vaccines. So things to think about there. Next slide, because I know we're running short on time. How to strongly encourage vaccines. Here's some resources that are helpful to you, especially if you want to put forth kind of an information campaign to help people feel comfortable. The other thing that's a big discussion is incentives. If we go to the next slide, we all heard from where we probably read about the fact people were offering Xboxes if you get a vaccine. There are a lot of, very aggressive incentives being offered. The EOC came out beginning of January and said, look, we have some proposed rules where we're limiting incentives to wellness programs to, a water bottle or a $20 Starbucks card. And that was largely seen in response to concerns about employers offering crazy incentives for the vaccine, which were no longer incentives, but basically coercion. Then the Biden administration withdrew those proposed regs and said, we want our new EOC chair, who had just been named, to look at them. And which is sort of normal and customary, doesn't signal they're going to go backwards, but change of administration. SHRM and the Chamber of Commerce have asked the EOC, can you really quickly give us guidance on what we can do? Because this is urgent and we need to know. So hopefully we'll get more guidance. I will tell you, I am working with our benefits group. We have a large benefits practice because there's still HIPAA violations if the incentives are tied in any way to your healthcare plans. So we're trying to do a workaround. I'd also say that think hard about, there's a lot of people that are going to get a vaccine no matter what the incentive, and there's people that are not going to get a vaccine despite the incentive. So incentives may be something that you want to think twice about, whether that's something that's worth the investment. But time off to get the vaccine, something you may want to consider. All right, next slide. Okay, let's skip ahead a few. Next slide. Real quick, there are some changes in how you're interacting with folks when they give you notice that they've been in close contact. The CDC just came out and said, if you have a vaccine, you may not need to quarantine as long as you're asymptomatic. So that may change some of your letters and your protocols in terms of your quarantining. And then next slide. There is some immunity for employers, but it's limited. It's not here yet. It's vetoed in Pennsylvania. I wouldn't bank on it. Next slide. Okay, third parties, visitors, vendors, customers. Do we have to mandate that before they can come on site? Keep in mind, there's a dichotomy between public and private accommodation. And if you're considered a public accommodation, where you're inviting members of the public, you still have to provide accommodation for religious and medical reasons. So something to keep in mind. Next slide. And next slide. So I just want to put a shout out here. Debbie Hart and her team have put together a BioNJ Return to Work task force, always working for her members. And so that task force is taking a hard look at all of these issues and putting together some guidance. And one of the first things was done, if we put the next slide up, is there was an informal, and for those of you that are in the science of surveys, this is very informal, but talking to some board members just to take the temperature about a mandate versus a strongly suggesting a vaccine for BioNJ employees, for example. You can see people are leaning towards a strongly suggesting the vaccine. Also trying to figure out what do we do with meetings going forward, right? In this new normal, which Dr. Strom really kind of took the air out of balloons, right? In terms of the new normal. So these are things that this task force is looking at, and we'll be coming back to you with more information. Next slide. Just real quick, there's we now have, we're in China, we're in the UK and London, so it's been great to kind of get information as far as what's going on in other places other than the US. We're learning from each other. We've taken some global surveys. It's really interesting what's happening as far as the vaccine and how other countries are responding. So lots of information to be continued. We have some resources on our website. You'll have the materials. We're going to be coming out with an issue spotting guide next week with regards to the vaccine. And thank you for your time. And with that, I'll turn it to Debbie.
Thank you so much, Lynn. And, Lynn mentioned the task force and gave me lots of credit, but meanwhile, it's Lynn, people like Lynn and Martin and other experts and board members who will really be doing the yeoman's work to come out with some recommendations in the near term. We actually have our first task force meeting tomorrow. So watch for, more to come. So Lynn, thank you so much. As always, we could just listen to you for hours. You're just always chock full of critically important information. And so thank you. And we'll be talking again tomorrow, as I mentioned. Okay.
Thank you, everyone.
So let's see. We are going to move to our panel. We do have a panel of HR leaders who are going to be discussing empathetic leadership, how to weigh and evaluate the new work paradigm. When we brought this group together a week or so ago to, talk about what they might talk about, I have to say several times during the conversation, I got literally choked up at the kinds of things that they all are doing to take care of their team members, their employees. And it's, I hope that you'll enjoy this discussion and glean as much out of it as I did. So to moderate the discussion and introduce our panelists, I'd ask you to welcome Chief Culture and Community Officer for PTC Therapeutics and the designer of this entire session, Martin Rexroad. Martin, over to you.
Martin, you're on mute. If you can unmute, please.
There we go. You knew that was going to happen. So anyway, Debbie, thank you for the welcome. Just reflecting on the title of this HR brief, vaccines are here now, what? Planning for the next 6 months. If you think about 1 year ago, I remember looking to Italy at hospitals being run over with too many people and too many deaths. And a couple months after that, things got really bad here in New Jersey and New York. And here we are a year later, and we're really looking at this new way of work. It's coming. I think we heard that from Dr. Strom. And so we've heard about vaccines and about the variants and the future. And Lynn has provided us great counsel on how to prepare for things. But what we wanted to include in this last session was, what have we done as HR professionals that's really, really made a big difference in the lives of our employees and our colleagues at work? And that's the topic of empathetic leadership. And so I want to welcome our panelists, Nicolette Sherman, who joins us from Oyster Point Pharma, Jamie Johnson, who joins us from Insmed, and Liad Amir, who is at Leo Pharma. If you don't have connections with these three people in LinkedIn, you're missing an opportunity to be connected with some of the key leaders in HR in this community. And I'd encourage you to do that. We want to share a little bit about empathy and leadership. And I'm going to start out by asking each of our panelists to tell us a story of where they've seen empathetic leadership in action. And my suspicion is that we're all doing more of this. It comes easy to us in this industry, but they have huge, huge impact. And so to get us started, Liad, can I start with you and ask you to share a story from your organization about empathetic leadership in action? And welcome.
Yeah, it's nice to be here. Thank you for inviting me. So when Martin and all of us spoke last week, I had a different story, but now I have a story that is near and dear to my heart, and it's actually about me. And last week, there was something happened in my family, and my wife, she's okay. She fell down the stairs. And I needed the support with my kids. And I had a conversation with my boss about it. And his first reaction is just take the week off. Just don't worry about it. Tell me what meetings you have. I'll cover everything for you, which felt incredibly empowering and incredibly amazing to have such a leader who was supporting me. Obviously, I didn't feel compelled to do that because he still obviously have his own job, but just the understanding and the sheer fact he offered it make me feel extremely valued in an organization that drives empathy across the board. And, if I sit here and say all of the research shown that, most people leave a job because they have certain relationship with their job or with their boss, or they don't. This is one of those reasons that makes me want to stay in an organization that supports me and have huge empathy towards my personal life and knows that my work is not going to suffer because of that. So that was just one story that really near and dear to my heart, and actually happened last week. So I was excited to share it with everybody.
Well, thank you for sharing, Lita, and I hope your wife is okay and you and your family are doing okay. Jamie, if I could bring you into this conversation and welcome and thanks for being part of this. Can you share a story with us of where you've seen empathetic leadership in action at Insmed?
Sure. Thanks, Martin. And with Leah's theme of personalizing things, I think I'm going to throw myself into this a little bit. So organizationally, how we've really shifted how we work and how we approach individuals with what they have happening outside of work has completely turned on a dime since where we were a year ago. And we were always very flexible to begin with. But with the way that we are now all working and living, regardless of if you have kids, you have elderly parents, you have other family members that you help, maybe you have a dog, maybe you have a cat, whatever it may be, everybody has things that are happening outside of work. And unfortunately now, work and home has completely collided. Uh, Things that used to be seen as a disturbance when you're on a video call are now seen as something that is now welcomed and brought into the conversation. So making it a little bit personal to Leah's story, I myself have 3 young children and my husband is an essential worker. So he does have to leave the house every day. And with school and childcare and health and safety concerns being where they are, my children are now a big part of my work day. And as opposed to my boss and my team seeing them as being a disturbance, they are welcomed into the conversation. My son works next to me when he's doing schoolwork, and we're able to really feel like we're able to still get what we need to do done at home, but also still be effective at work. So having that level of flexibility and comfort that if somebody's loud in the background, or if there's a delivery, or if my dog jumps up on my lap while I'm in a meeting, knowing that will be accepted, to me is really at the crux of what empathetic leadership is.
Thank you. So, Jamie, just to put you on the spot, we've got a couple employees at PTC whose children want to come and open meetings now and wave. Are your children meeting greeters? That might be a new role that emerges. Are they meeting greeters?
So they're very involved in my meetings. I don't know if I've ever had them open one up yet. The only thing that I try to not have them be a part of is when I interview or work external to the organization. But they are literally background noise and active participants in team and client meetings throughout the organization. And people know them by name and ask how they're doing on different things, which is really nice too.
Yeah, that's a great story. Thanks for sharing. And just one of the things that I heard from somebody yesterday is they were saying as it starts to warm up and spring is in the air, apparently there are a lot of birds that get in a tree or a bush near their windows, and so now they're having to deal with singing birds during Zoom meetings, which strikes me as nothing but fun. So Nicolette, welcome, and thanks for joining us from Oyster Point. Share with us a story that you've got from your company with empathetic leadership in action.
Yeah, so I think, there are a number of things that come to my mind, and Jamie, I love the perspective of the collision of kind of work and home, because I think we're all experiencing that for sure. And so the stories have resonated. And so if we're going personal, I'll just keep it personal to make it a trifecta here. Similarly, all of us have home things going on, and my mother was diagnosed this end of last summer with stage 3 follicular lymphoma, and she lives alone. And so, figuring out how to kind of get her to her care, where she needed to be, while trying to kind of manage everything at work, it was a little bit tricky, right? And I think similar to what Lee had shared, my boss was very clear that that was the priority, and that, that we would work around it. And it's really taken a big pressure off of me. And I think that's how we're trying to lead forward. I think we're trying to lead forward. I mean, in this time, I think flexibility takes on a whole different tone, right? And so, to Jamie's point, we all are having different visitors coming through our Zoom screens, and we're all having doorbells ring or dogs bark or whatever. And it's almost humanizing more of the workforce, or bringing much more of the personal into the workforce. And so I think, flexibility takes on a whole different tone, and so does communication, right? So we do, if I kind of bring it a little bit bigger picture at Oyster Point, we do weekly company meetings, and it's just a chance for everybody to connect, to hear what's going on, to to kind of feel that validation of the group coming together, and sharing updates, sharing ideas. And that's really important. Now, we're a smaller organization, we're 75 people, so so we can still do that pretty easily. But I think that element of communication is key, both top down, and then critically at the middle point with managers saying, how can I help you? Opening that door and making sure that, that people know that it is okay.
Thank you, Nicolette. I've actually come across a couple people who've told stories of colleagues in other industries where people are getting fussed at for noisy Zoom background, and I'm guessing those companies won't be employers of choice if they ever were. One of the great values of briefings like we're holding today is to share ideas and best practices and programs that some of us have implemented and we find are working real effectively. So if I could, to go around and ask each of you to share with the audience here, what programs have you brought into your organization that really highlight empathy and demonstrate the leadership of your companies to care for each other? And if I can, just to mix it up a bit, I'll go reverse order. So Nicolette, if I could start with you, what sort of programs that you have that would be great to share with everybody? This is the moment where you can't see it, but people have got their pens ready to start taking down notes. So what do you got for us?
That's right. Well, so we do a number of different things. I mean, we try to keep it fun, try to keep it interesting, try to keep it relevant. So that communication theme gets really resonates for our employees, because we survey them fairly frequently, not to be annoying, but just to understand what's on their minds. We've done things that I think many companies have done. So we have a subscription to Headspace. We are connected with Bundle Cares that really helps give employees some dedicated time, that really responds to the needs of their children or their elders. One of the things that we just launched now, though, that I think is going to be a hit is a wellness, kind of a wellness initiative. So we've retained a coach. And so we're doing a number of things, with this focus on not only it's both physical and mental well-being, right? So things like meditation, things like nutrition. He's offering coffee with a coach. There are weekly Zoom exercise classes. And so there are a whole host of things. And we're doing some challenges. And it's really pretty fun to see in your company, where you have the real competitors too, like people that want to go crush a goal and feel real motivation. So even though we're remote, there are ways of being able to kind of continue that connection. And importantly, and I say it with a smile on my face because, it seems fairly lighthearted, but that connection piece is so critical for, for all of us, I think, when we're in this very, still this very difficult and unusual period. And so I think we're trying to learn new ways of getting to know each other, build relationships, manage some kind of balance that keeps us healthy, while we're working and trying to be as productive as possible.
Hey, just a follow up on Mindspace. Not everybody might be familiar with them. Could you just say a little bit more about them and some of the other kind of online resources that you might be using that might be new as a result of the pandemic?
Yeah, sure. So so sorry. So Headspace, right? So Headspace.
Headspace, sorry.
No problem. So Headspace is it's actually an app that enables people to kind of come into meditation and mindfulness at their own pace, right? So there are a number of other I'll say competitors or other companies like Calm or like 10% Happier, to name a few, and many of them offer corporate subscriptions. But the way they kind of enter you into it is you don't have to be what do I want to say, a real accomplished meditator. You could go in and do something for a minute or 2 minutes just to kind of catch a moment and catch your breath. So they make it really accessible for people, and there's a lot of research on on really the effectiveness of being able to take that step back, and literally just kind of focus, even if it's just focusing on your breathing.
Just got a question, and somebody was asking if you could say a little bit more about bundle care as well.
Yeah, so and Bundle Cares is a provider. They started out in the space of providing benefits, and again, this is a monthly subscription that you would have based on the number of your employees that are actually participating. So you need to forecast that out a little bit. But Bundle Cares is essentially providing an hour of time, focused time with a child in a certain example, or it could be an elder. They've recently broadened their benefits to also include some team building types of activities or some activities for us as employees too. The initial focus though was on, if perhaps your child is interested in geography, then you could sign them up for an hour for geography. So, or if your elder wanted to learn a language, something like that. So again, depending on, your needs, just an opportunity for you to take a step back, or if you knew you had a really critical meeting and you wanted to find something productive and instructive for your dependent to be involved with, it gave you an opportunity to kind of have them well cared for during that time.
Terrific. Thank you, Nicolette. Jamie, back to you. And I'm going to be disappointed if we don't get to meet your family here by the end of this panel, but maybe that's not possible. But anyway,
Yeah,
what do you?
unfortunately, you're not going to meet them today. If you see me looking off in the distance, I actually have cameras in my house now, so I could see them when they're in a different room, which is interesting.
Nice. Well, I know you've got a lot of programs going on at InsMed as well that are really focusing on empathy and demonstrating real leadership and caring for your employees and their families. Can you share some of what you're doing at InsMed?
Yeah, sure, absolutely. We're doing a lot of what Nicolette shared, slightly different organizations, but very similar programs, really with an emphasis on communication to our employees and trying to give different opportunities to different individuals that may need different things at different times. One thing that we do have in place, which we actually had in place well before the pandemic, but we have found it to really be advantageous given our current situation, is professional judgment vacation time. So, professional judgment vacation time is for all of our employees, regardless of where they sit around the world and regardless of their level or their tenure with the organization. We don't have a bucket of vacation time. So, although of course we do ensure that we have the 5 sick days that are set aside above and beyond what we really offer broadly to make sure that we're in accordance with New Jersey state law, we really have a very flexible, though not unlimited, people love to use the word unlimited, but an incredibly flexible personal and vacation time program where folks use what they need when they need it. Everybody has different things that are going on at different times. Some years you may need a little bit more time. It may be for fun. Maybe you're going to plan a trip to Europe, hopefully one day again. Or maybe you're going to go on, a cruise that you've always wanted to go on once again, hopefully soon. Or maybe you do have somebody in your family that needs some additional time, or maybe you're doing a project around your house. Whatever it may be, we feel that putting a parameter around time off that we're offering for folks really can limit or prohibit people from taking the time that they need. It also contributes to who we are as an organization, which is a very flat organization. So, a lot of companies, depending on how long you're there, really your level, you have more time to choose from. So we don't want to, encourage that type of behavior either. We want anybody, regardless of if you're new or, if you're a vice president or an associate, that you have the same ability to take the time off that you need.
Wow. So what sort of things are people doing with time off now in the pandemic? Have you heard of any interesting ways of taking time off? Some of it is just to break away from the Zoom calls and all that, but have you heard any interesting sort of things people have been able to do?
So it's really interesting. I think that in 2021 we are going to see people start to really take some time again, really start to get away, or I think we all hope that as we go forward. I myself do hope that as well. In terms of the last year, what we've really found, which is nice, is people can take time in snippets of whatever they need. So a lot of times when you have a bucket of time that people have to take from, if you have to go to a doctor's appointment, or maybe you're having a rough day and you need to take a few hours at the end of the day, trying to request that time and really make sure that it's being banked appropriately is more difficult. So I think we've found that in this environment where people might need different time, or maybe more last minute time or smaller chunks of time, that people can just take it whenever they need it. And we've heard really good things from our employees with that.
Terrific. Thank you for sharing. Leah, back to you. What are some things you're doing at Leo Pharma where you've got some new programs that are demonstrating empathy and really demonstrates the leadership that you and other leaders have in the company?
Yeah, I mean, to us in the organization, it was very important to break barriers and silos. So we've done a lot around how do we get people connected, and some of the things we put into place is a lot of fireside chat, small groups, so you can actually get to know people, not just work related, but get to know people on a personal basis. What are some of their hobbies? What do they like to do? Where are they coming from? Their background. So when the time comes, they feel comfortable reaching out and having those conversations. It's funny, the role of HR is changing drastically, I would say, the last definitely year and a half, as far as what the organization is expecting us to deliver, and around empathy and engagement and culture is definitely a top priority. So some of the things we're doing is providing the leader with icebreakers when they go into those conversations, so they can, there's not going to be a dead silence when they go there. So that's one example, which I completely recommend. We've also built a really amazing group that is led and driven by the people, for the people, and they're driving initiatives across the organizations on things that are related to volunteering and entrepreneurial and culture and engagement, as far as wine tasting and wellness. So they're driving initiatives based on what they hear in an organization. So far, it's been it's phenomenal. The last thing I would say around leadership and empathy, we've realized that real life examples from people who've been there, those difficult times, are so powerful. And we've brought in guest speakers who served in the Army, and every month we have this presentation that they provide, and they provide some phenomenal examples. Then when you're done with that conversation, your own individual issues just seem so small, and it just provides people with a lot of clarity and understanding that where we are experiencing right now will go away. And then you kind of go back with your own team and have a discussion on that. And again, getting to know the people and the things that are bothering them. I want to just stress this is really interesting, because up until recently, we always had that firewall between what we ask our managers to talk and say with their employees. And it's changing. That time is changing. We're almost getting back to being human again, friendly, caring about each other. It's such an incredible time, at least the way I see it. Don't get me wrong, they don't talk about things that they shouldn't, but at least the getting to know like how many kids you have and things like that is just it's incredible, and it helped a lot. So those are a few things that we're in the organization doing. I mean, we have Volunteers Day that people kind of take advantage of, which is fantastic. And the last thing I would say is, to answer the question you asked Jamie, I've learned even from my own experience that sometimes taking a day off by shutting off your computer and phone and just doing absolutely nothing, it is so incredibly refreshing. Or just going for a walk, or just shovel the whole day if you're in New Jersey. It's just extremely refreshing, and definitely recommend it.
Well, thank you, Leah. And just to share some closing comments as we wrap up this session. First, I want to thank the three of you for taking your time to be part of this panel and to prepare and to share such great stories from each of your companies. And I think when I think about empathy and I think about this pandemic, one of the statements that I've shared with people is that the care that you had for the people in your organization coming into the pandemic has been tested, we've been asked to do more, to care more, and to care in more ways. And I think that some of the stories that we're hearing today and some of the stories that we hear back at work, they were always there. Parents always wanted to not be so worried if there was a little noise in the background, or if a family member got hurt, you could talk about it, and the response wasn't, "Are you still going to get the report to me on time?" Right? And the closing out the week, Nicolette, as you're doing at Oyster Point, where you kind of get the community together and talk about things. We've always needed this, and it seems that the pandemic, and Leah, you might have used the word the humanity, and not for nothing, human is in our titles, right? We're in human resources, and it really gives us a chance to be authentic and caring. And I do think that these are things that we've done that are going to continue and be part of us, fortunately, after we get the virus under control. And with that, Debbie, I'm going to turn things back over to you so you can close us. And again, thank you, panelists.
Thank you. Thank you so much, Martin. Thank you to the entire panel, Leah, Jamie, and Nicolette as well. Thanks for sharing, those really heartwarming stories. I hope that, maybe lots of you are doing a lot of those things. I hope that you did learn some things along the way. I'd like to thank this morning's sponsors, PTC Therapeutics and Faegre Drinker. Thank all of our speakers, Lynn and Dr. Strom. And of course, thanks to all of you for joining us. I really hope that you've found the discussion to be valuable. We hope to see you at future BioNJ events, including, I have to give mention to our inaugural Diversity, Equity, and Inclusion Conference on March 24th and 25th. We are very, very excited about that. And I would invite you to visit bionj.org for details. And thank you also for all that you do each and every day on behalf of the industry and ultimately for patients. Please stay safe and stay well, because we need you doing what you're doing out there. Thanks and have a great day.
Thank you.